Afternoon, everyone. So at Marigold Health, we use AI-augmented chat support groups to reach and retain vulnerable patients in community-based mental health and substance use treatment. And when I say vulnerable, right, that's a broad term. Generally, we're talking about designing for the folks that are least likely to engage with the outreach strategies that we currently have. So that includes a lot of folks on Medicaid, a lot of different minority communities. But again, it's a term that we're still learning a lot about, especially in the behavioral health space where the majority of people with the mental health and substance use condition aren't actually getting any treatment. So if you take, for example, substance use, which is the area we focus in, NIDA has a stat out that says that 10% of the people with the substance use condition are in clinical care at any given time. And the reason I bring that up is to really illustrate how important that is to our understanding at Marigold and how we can help with this problem. Because it's not enough to just make the care more accessible and more engaging for individual patients. You need to fundamentally figure out a way to increase capacity in the system itself. Because if you increase access for all these patients, you need to somehow actually give them care to engage with. And that's why with Marigold, while we're using text-based support groups to personalize support for individual patients, the true scalability in our model is in the fact that by getting patients to engage each other, you can make behavioral health care itself a lot more scalable. I wanted to use this talk as a chance to basically step back a bit and tell you how we came to build Marigold the way it was. Really, the only main takeaway here is that there isn't any one person's experience or story that kind of just created this product. There's a ton of experience that goes into this, but above all, building an early stage company is about listening and observing and really just being patient and empathetic to actually get an understanding of why things are the way they are. Now, for me personally, I became invested in this problem space very early on, actually at the very start of my career, in my last year of high school, when I was just starting off as an EMT. So I left EMT school prepared to handle a wide range of scenarios that included amputations, fires, car accidents, even a literal terrorist attack. But I really wasn't prepared to deal with the sheer volume of behavioral health emergencies, overdoses, and suicide attempts we ran on a regular basis. And as a young EMT, this was a very difficult call for me to run because these patients would be lucid. They'd talk to you pretty much the whole way through. And there was always that hope the first time you saw someone, when you dropped them off at a hospital, that you had just caught them during a bad time, and now they're going to get referred to, right, whatever resource they need. And they're basically going to go on and be a healthier version of themselves. Of course, in reality, what ended up happening, right, was I ran these patients again and again. Some of them even knew me on a first name basis. And when I talked to them and I asked, what's happening, usually the answer I get was, it's not actually that there was a shortage of resources where we were. It was that whenever you were referring these patients to social work or some type of outpatient care, they weren't actually retained once you made that referral. And this is how the majority of people actually interact with the behavioral health system in our country, right? In a very sporadic kind of way. The longer I also worked as a first responder, the more I realized that even the people that were next to me on calls weren't immune from this. I saw fellow first responders struggle from things like PTSD and substance use. And here, the access was so easy, it was practically a joke. We had free care through our department for this textbook situation, but I never once saw a single person voluntarily use those resources because of really the stigma that was attached to these conditions. So that experience alone was pretty much enough for me to decide what I wanted to work on. It was pretty clear that we had a way of handling mental health conditions that did not do a very good job of meeting people where they were at. Now the how, how I would actually do anything about this problem, was a lot less clear. So when I went to Johns Hopkins for my undergrad, I was just trying to learn as much as possible. I did some academic research at Bloomberg. I even actually started planning for med school. But the most salient experience I had was at a nonprofit in Baltimore called Thread. And what we did at Thread was we mentored and engaged underperforming Baltimore City high schoolers. So I was responsible for 8 kids. And the biggest challenge we had was actually just getting in front of them and engaging them. Half the battle, right, was tracking them down, right? They had changed their address every week, keep on changing phone numbers. But even once I was in front of them, right, I usually buy someone some Burger King and try to ask them about their plans. And I was the grown-up telling a teenager to do his homework. So 1 or 2 word answers if I was lucky. But it was night and day when I actually started texting these kids. And over text, I was getting memes, I was hearing about their curl problems, I was hearing all these things. There was no way in hell they'd ever tell me face to face. And that's kind of when I realized that fundamentally, text as a medium is something that we're underutilizing for actual human interaction. Because it's so natural for us to think of what we lose when we go to text, right? I can't stare at this person and see their emotional reaction to the sentence I just said. But what we don't consider is that for a lot of people, that space can actually be extremely empowering, right? It gives you the ability to share at a time and place of your choosing, to reread each message before you send it, and to not have another human being judging you as you send that message. And when I looked at what was my experience with text in the healthcare system, and it was appointment reminders, purely transactional, right? We're missing the idea that some patients will actually open up in a very unique way through this modality. Now, right, the modality, it's only half of the picture, right? Because you can get someone to reach out through text, but the second step of actually giving them a response where they feel heard, that actually leads them to commit to some kind of behavior change is a lot tougher, right? And that's where I was totally out of my depth, right, as a Hopkins undergrad. I could certainly teach these kids calculus, but there was really little I could do to relate to them and their situation. But what I realized was that relatability, it doesn't necessarily have to come from me, right? They're surrounded by peers with similar experiences. And even in the clinical case, the place where you get your counseling or your medication doesn't necessarily need to be the same place where you're getting the validation and the encouragement you need to basically keep committed to care. Now, it so happens that at Hopkins at this time, I wasn't the only one thinking about this kind of thing. My co-founder, Ravi, a master's student in computer science, actually had a close friend who was in therapy, but who was getting very lonely in between the sessions. So for her, we built the first version of Marigold, which was a small group chat that patients would join and text into this chat 24/7 of just 5 to 20 other people. The patients were anonymous to each other. They chose a username that they shared under, and the only person who knew their personal information was a treatment provider that was actually offering the group to their clients. Now you're probably thinking, okay, well, you built a group chat, congratulations. And in terms of the precedent here, peer support was very well documented as being effective in the behavioral health context, right? 39 states are already reimbursing face-to-face, one-to-one peer coaching in some form or another through their Medicaid program. But the challenge is when you go to a group setting, even though you have all these really engaging groups in the community, 12 steps, AA, NA, the problem is regulating the interactions between group members and making sure they stay constructive is really hard. If you talk to patients, you will hear many patients tell you stories of going to an NA meeting where a drug dealer showed up. Or you go to a Reddit forum for support, and there's trolls telling people to go kill themselves. So we realized, though, that this was actually where technology could make a massive difference. That we could lean on our background as engineers and design a natural language processing, or AI system, that would understand the emotional sentiment of messages sent in this chat and automatically detect when something was clinically relevant or required provider intervention. So for example, a patient going through a crisis, or even giving another member of the group improper medication advice. And what this did was it made it so that the providers did not have to read every single message in these group chats in real time. And it transformed the group chat itself from a potential liability to a source of extremely granular, high-fidelity information about how a patient was doing in the community at a given time. Because when it comes to mental health and substance use conditions, right, we don't have any way to actually track how these patients are doing when they're not right in front of us. There's no biomarker, really. All the diagnostic forms are self-reported. And just by getting them to talk with each other and open up about their lived experiences, we had this new source of data that the patients are very comfortable giving to us. They actually took the lead in organizing these groups. But more on that later. I mean, essentially what then happened was I took a leave of absence from Hopkins. We hired our chief data scientist, Satya, convinced him not to do a PhD program at Hopkins and to instead come on board as employee number 1, which was a miracle in and of itself. We then moved in with him because Ravi and I didn't have any place to stay. So it was the 3 of us in Satya's studio. And our number 1 goal, right, was to build something that people would actually use. So we partnered with over a dozen consumer nonprofits. We gave them product for free. These were primarily patient groups formed by patients who had this experience, who were just supporting each other, right, in their own local communities. And we gave them this app for free to basically understand, how can we actually be useful here? And that's where we learned what it actually meant to, right, build an app that's accessible for a Medicaid population. It means it's not enough, right, to just be iOS and Android. You've got to be iOS, Android, and you've got to go all the way down to the Obama phones, right, which are the free phones that are given out at the welfare office. If your NLP tools are going to understand Spanish, they need to understand that most people who speak Spanish are actually going to choose to message in English, but then use Spanish idioms. So how do you actually account for that? And above all, it also made us realize that in most care settings, there are patients who are very stable in their recovery who are more than eager to volunteer and do a lot of the day-to-day engagement in these groups, which made it so that if you're a provider, there's only a very small subset of messages within this chat that actually require your intervention. So after a year, more than a year of doing this, we had a product that consumers were really excited about. And that's when we approached Rock Health and some other great investors at the end of 2018 and closed our first round. And since then, we've scaled up our operations pretty significantly. We're live at more than a dozen community medication-assisted treatment facilities in our home area of New England. We have a lot of other implementations that are currently underway. We have clinical funding to run studies with partners at Hopkins and Brown. But the best thing really about rolling the solution out is that we have a model that's sustainable on day one. By partnering directly with outpatient treatment providers, we can increase retention and adherence in the actual care that they're offering, because that's the effect you're already seeing from these face-to-face peer groups. And then working with those provider partners, we can approach an MCO or an MBHO to fundamentally show that we're stabilizing these patients, right, at a community level of care, right, which is going to translate to a reduction in detox days and all sorts of other clinical outcomes, because the way to manage these behavioral health conditions is through consistent low-level engagement. We just don't have a scalable way to do that right now. So in terms of the research we've seen to date, it's very early for us, but what's really exciting is we've been able to see that we're reaching patients that aren't currently reached by other outreach. So of our patient population, 60% of them are what our provider would consider clinically high risk. But also 60%, that 60% is never engaged in the current care coordination that's offered by that provider, even though it's offered on site. So there's something fundamentally different about approaching someone with a peer support group versus approaching them with any other type of more standard intervention. So as I kind of go to close here, I think the one thing I really want to stress is that a lot of the pieces of what we're doing, the peer support, the text, it was already being done in a lot of different contexts. And our insight was really recognizing that you could use technology to create a platform to facilitate those human-to-human connections, right? To understand what works for a specific population and why, and then scale it up immediately. And in the context of our healthcare system, this is really important because when we're trying to reach out to underserved patients, so much of our work is just trying to understand the need, just trying to understand what they have to say, just literally like driving food trucks into these communities to try and get in touch with people. But now we have a platform that consumers will organically engage with on their own. They'll take the lead in creating these groups and helping us create models for different populations, and ultimately, right, like organize themselves and voice their concerns in a way that can easily be translated to their care team and can easily be used to triage their outreach. So we're in a period of pretty significant growth ourselves. So if you're looking to do any type of significant work in expanding your community-based behavioral health infrastructure, I'd love to tell you more about our work. But otherwise, I'm just really humbled to have been able to be here and share a bit of our story with y'all. Thanks.